Hello, and welcome to the Dance Physio Podcast, a podcast designed to explore ideas and foster discussion around dancer health and wellness. We're here to challenge the status quo, bridge the gap between dance science and the studio, and help change the landscape of the dance industry for the better. I'm your host, Erika Mayall, a dancer turned physiotherapist who is deeply passionate about leaving the dance world better than I found it. I'm so glad you're here. Let's get started. Hello, everyone, and welcome back to another episode of the Dance Physio Podcast. I am your host, Erika Mayall. Today, we are going to dive in and chat a little bit about ACL rehabilitation and specifically post-surgical rehabilitation. So if you listened to last week's podcast episode, you know that I talked a little bit about ACL injuries, but much more from the perspective of prevalence and incidence of those injuries, and a little bit with regards to injury prevention when it comes to ACL and the difference between sporting populations and dance populations and a whole bunch of stuff like that. If you have not yet listened to that episode, definitely check it out because it kind of goes hand in hand with today's episode. But today, I specifically want to dive a little bit more into the rehabilitation side of things. So I didn't cover that at all in terms of like really specifically what an ACL injury is or how we deal with them in the dance world. So I thought that we would dive into that. It may have made a little bit more sense to do these episodes in the opposite order, but like I said, they do go hand in hand. So if you have not yet listened to last week's episode, you won't know, but we talked a bit about how ACL injuries are not one of the more prevalent injuries within dance populations. The incidence of them is actually significantly lower than other sporting populations, but that does not mean that they do not happen. We certainly do still see ACL injuries, and when it comes to the rehabilitation from those injuries, it is a little bit different for dancers than for other athletes. So that's what I want to highlight today is more of the, a little bit of those differences or how we have to treat dancers slightly different than the general population or a general athletic population. But before we dive into that, I think it's important for everyone to understand just maybe a little bit more about what the ACL actually is. A lot of people have heard about it because it is such a common sporting injury, but you may not actually understand sort of the anatomy or even know what it is. So the ACL stands for anterior cruciate ligament, and it's one of the main ligaments in our knee. So we have essentially four main ligaments in our knee. We have two cruciate ligaments. We have our anterior cruciate ligament and our posterior cruciate ligament. And they get their name, cruciate I think means cross or something, and they get their name because they like cross each other and sort of form a cross right in the center of our knee joint. And the anterior cruciate ligament starts on the femur, so on our thigh bone, and it kind of attaches a little bit towards the back of the thigh bone, and then it aims itself, or it dives forward, or we call it anteriorly, and attaches onto the tibia, so our lower leg bone, and it attaches a little bit more towards the front of the tibia. So this anterior cruciate ligament runs from the back to the front, and then our posterior cruciate ligament sort of does the opposite. The anterior cruciate ligament, well, both the cruciates, but specifically the anterior one, are really, really important for controlling how much translation movement there is that happens between the femur and the tibia. And the ACL specifically controls anterior or forward movement of the lower leg, the tibia, relative to the femur in through there. So these ligaments, both those cruciate ligaments and all the ligaments in our knee, are very, very important for stability. The other two major ligaments in our knee are our MCL, which is the medial collateral ligament, and the LCL, the lateral collateral ligament. So these ligaments are more on the outside of the knee joint. So the MCL being on the inside part of the knee and then the LCL being on the outside part of the knee, but they are both lateral stabilizers. So they control a little bit more for sort of side-to-side type movements, and then the ACL and PCL control more for forward and backward movements, and the ACL specifically for that forward translation. All of these ligaments are also really important for rotational control within the knee, and the ACL in particular. So when we have injuries to the ACL, More often than not, and we talked about this a little bit last week, we see a lot of what we call non-contact injuries. So these aren't somebody getting like smashed in the front of their knee and injuring it. It's oftentimes an injury that happens from some sort of a change in direction, a pivot, a shift, a deceleration type movement. And you can sometimes, if you see footage of like the moment when somebody tears their ACL, and especially if you like slow it down into slow motion, you can often see that exact moment it happens, because you'll see a big shift or kind of translation that will happen in the knee joint the moment that ligament sort of lets go. So again, they happen a lot from these changes of direction, deceleration, and in a dance population, more often than not, these are going to be from some sort of an unstable landing, and usually from like a jump of some sort, where maybe there's a little bit too much of a rotational movement, or maybe you lose control of the knee sort of into like a valgus or like a caving in type direction, and the ligament gives out or gets injured in those instances. With ACL injuries, it is common, I don't know if that's the right word, we'll say common, to also have injuries to some of the other ligaments in the knee, oftentimes the MCL, but depending on the mechanism of injury, it could be the LCL as well. But we will often see MCL injuries, and we will sometimes see meniscus injuries in conjunction with those. And again, it just has to do with the mechanism of injury, like what happened to the knee at the moment of injury. If there's a bit of a rotational component, it is very common that the meniscus might get injured at the same time. And so when we are thinking about rehabilitating these injuries, the timelines are going to vary a little bit based on how much damage there was to the knee. If it is an isolated ACL injury with no other damage to the meniscus or the MCL or any other structures within the knee, this timeline might be accelerated a little bit, or we might have like faster recovery and return to dance. If there is involvement of any of those other structures, then the rehabilitation protocol is essentially the same. It might vary like a little bit, especially immediately post-surgically, if they're also like addressing issues within the meniscus. But for the most part, the rehabilitation protocol is very, very similar. The timeline just might be a little bit longer. So I just want to mention that, because you will hear varying accounts of how long it takes somebody to get back to their activity, and in this case, dance, after an ACL injury. And a lot of that variation in timeline depends on how much other damage there was in the knee joint at the same time. So the ACL is a ligament, just like other ligaments we've talked about on the podcast before, like our ankle ligaments or anything like that. And so when we have injuries to it, we can still grade these injuries on like a grade 1, grade 2, grade 3, the same as we would with any other ligament sprain. But we oftentimes only really talk about or pay more attention to the people who have a grade 3 injury. So they've ruptured or fully torn that ligament. And so when we hear about ACL injuries or ACL tears specifically, I think sometimes people think that this is like a different type of injury, but it's not. It's still a ligament. We just hear about it a lot when it is this full tear. So a grade 3 tear of this ligament. And in those cases, the treatment for it, and especially in an active population, so in dancers, the treatment for it is going to be a surgical reconstruction. And so that's why you hear about ACL tears and people having surgery for their ACL. But we can have grade 1 and grade 2 injuries of ACLs as well, and those would not require surgery for the most part. So just to raise your awareness of that, because I think we only really talk about them when they're full tears, but just like any ligament in the body, we can have grade 1, grade 2, or grade 3 injuries to these ligaments. So, like I said, when we have these grade 3 injuries, and that's what we're going to focus on today, we are generally looking at a surgical reconstruction. Like I said, in a dance population, you're pretty much always going to surgically reconstruct it. And in any sort of like an active population, there are instances where even in a slightly active population, but if people are a little bit older and maybe more recreationally active, they may elect not to actually surgically reconstruct this. And so I've had clients in the past in, their 60s, let's say, and they're active in that they go to the gym, or maybe they ski a little bit recreationally, like in the winter and things like that, maybe a little bit of easy hiking in the summer, tear their ACL, and they may elect not to surgically reconstruct it because the level of the activity that they're doing can probably be managed with a really good rehabilitation program and potentially like bracing for the knee and things like that. But in a younger population, regardless of activity level, and in an active population, like higher level activities, which dance is included in that, we're pretty much always going to be looking at a surgical reconstruction. And one of the reasons for that is that the ACL, or most of the ligaments in our knee, but specifically the ACL, is really, really important for our knee stability, like I said. So if we lose the stability from that ligament because it's fully torn, there's a lot more shifting or wear and tear that happens in the knee joint itself, even just with everyday activities. And that over time can lead to early degeneration and sort of breakdown of the knee joint itself. So in the past, so let's say 30, 40, 50 years ago, if people tore their ACL, they weren't commonly reconstructed. Maybe if you were a professional athlete, they were, but for the regular everyday person, that would not have necessarily been the go-to treatment option. And we now know from watching those people age as they, progress through their life, that this was not ideal. They were often developing a lot of like early osteoarthritis or just degeneration of the joint damage within the joint, and then requiring potentially even knee replacements or things like that later in life. So we now know, and we now treat this as a sort of a joint preservation technique in terms of the sort of why it is that we sort of default to that surgical reconstruction. So like I said, especially if you're a dancer and you know you have a full tear of your ACL, you're likely not really going to be given a choice of like surgery or not surgery. Whereas in some other conditions, we're really going to try conservative management first. And if that doesn't work, we might resort to surgery. In these cases, that's not really how it works. It's like, okay, we probably want to surgically repair this to give that stability back to the knee to minimize the amount of damage that is going to happen in the future, and to just being able to get back to dancing at high levels, to be quite honest. As far as the surgery goes, there are two main techniques that they use, and the difference has to do with where they get the graft from. And the graft is like the thing that they use to recreate a sort of quote unquote ligament within the knee. So what is, I think was the first, maybe, I never looked into this, I should have, but I think this was like the first technique that was used, is what's called a patellar tendon graft. So the patellar tendon is the tendon that attaches from your kneecap to the kind of little bony bumpy bit in the front of your tibia. So right underneath your kneecap, there's your patellar tendon. And they go in and they take out the middle part of the patellar tendon. It's usually about the middle 1/3 of it, I would say. And they take that out and your patellar tendon will repair itself over time. And they use that piece of tendon that they've removed and they create an artificial ACL and sort of insert it, for lack of a better word, into where the ACL previously was. So patellar tendon grafts are very, very common. They are considered to be sort of the strongest or most robust in terms of creating stability within the knee joint when it comes to like reconstruction. So they are still a very, very common surgical technique that is used. But the downfall with them is that because of where they're taking out the tendon from the front of the knee, some people end up with some patellar tendinopathy or pain in that patellar tendon afterwards, which might limit some of their movements. And specifically like kneeling and things like that can be problematic, or people just always having to manage the loading through their patellar tendon afterwards. So it's not to say it's not like without a few little downsides. Any surgical technique is always going to have, pros and cons. So patellar tendon, the graft itself is considered very, very strong and very stable, but downside, maybe potentially more pain in the anterior knee or the front of the knee after surgery and throughout rehab. The other surgical technique that is also commonly used is what is called a hamstring tendon graft. And so in this procedure, they take a piece of your hamstring tendon, so the hamstring's muscle that comes down the back of your leg and where the tendon comes kind of towards the back of the knee. They take out a little piece of that tendon and they form that into a graft and they insert that where the ACL would have been. And so with the hamstring tendon graft, it's again, maybe, and all of this, like they've done a lot of studies trying to look at is one superior to the other. And most of them are fairly inconclusive, but they both have sort of pros and cons. So the hamstring tendon graft potentially has slightly less static stability. So if a person is, if you're statically testing how stable that knee joint is, and we use tests that are called like the Lockman's test, or there's a few different tests that we can use. The static stability on a hamstring tendon graft potentially may be less than on a patellar tendon graft. However, we don't often run into the same complication with that, or you won't run into the same complication with that anterior knee pain afterwards. There's also some interesting differences in terms of, what's what I'm looking for? Like the range of motion that people achieve post-surgically. And with the hamstring tendon graft, sometimes people will lose a little bit of end of range knee flexion movement, or it's harder for them to get that back. And with the patellar tendon graft, there's some thoughts that it's harder for people to get end of range extension, so full extension or hyperextension back. So again, pros and cons, and it might depend a little bit on like your own individual anatomy if one is more advantageous than the other. So just things to consider. I will say, especially here in Canada, you don't mostly have a choice in terms of which graft that they use. It really comes down to the surgeon and what technique they have been trained in. And where I am in Vancouver, we pretty much almost exclusively see the hamstring tendon graft. I actually I'm just trying to think when the last time I saw a patellar tendon. I'm not sure. Yeah, we mostly see the hamstring, which is interesting. I was having a conversation with a colleague who's based in the US, and she works with a ton of professional athletes, mostly in football. So she's seen her fair share of ACLs over her career. And she just recently was rehabbing a client who had a hamstring tendon graft. And she was like amazed at how quickly that athlete progressed in their early stage rehab compared to the patellar tendon, because they weren't dealing with anterior knee pain. And she was like, oh, like this rehab is so much smoother. Like maybe this should be the gold standard. And anyway, we had an interesting conversation because I was saying, oh, I never see the patellar ones. I only see the hamstring ones. So it really comes down to the surgeons in your area and what they are trained in. And they're usually not trained in both. So they're going to just do the procedure that they are familiar with. I will not say that we have conclusive evidence that one is quote unquote superior to the other. There are definitely slight differences, but again, they are both generally very, very successful surgeries, assuming that people do the rehabilitation afterwards. And so I don't think the surgical technique matters so much as just the amount of time and effort that is put into the rehabilitation afterwards, and then just being aware of what the differences are going to be in terms of how we go about rehab. So that was a long-winded way of just saying there are different surgical options for this, but it's going to depend probably on the surgeons in your area and what they are familiar with and what technique that they use. So after people have surgery, that is when the real work starts. And when we are thinking about post-surgical rehab from an ACL reconstruction, the timeline for return to dance or return to play in sports varies a little bit depending on the activity, but really is considered to be anywhere between 9 and 12 months. We used to sort of say it was a little bit more like 6 to 9 months, but then the rate of re-injury was fairly high in people who returned to sport within that first 6 months. Like, so if they kind of were in that, 6 months, 7 months. And so now I would say it's very rare to see somebody returning to activity that early, and much more likely that you're going to see people returning somewhere between like the 9 and 12 month mark. So ACL rehab is a long haul. We are not looking for, a quick return or the quickest return possible, because we know that the rates of re-injury are high if people return too soon. So oftentimes the rehab can get a little bit monotonous. It can seem a little bit sort of like quote unquote boring, because we have to spend so much time on the basics, and some of it is just a little bit of a time game. And so even if you have somebody who's meeting a lot of functional criteria at 6 months, we're probably still not going to clear them for returning to their activity until closer to those 9 months. So it might mean doing a lot of the same rehab stuff between 6 and 9 months, just to really like fine tune some of those neuromuscular patterns and things like that, and also just allow the body more time for healing. So I'm going to run you through a few of like the key phases or the key things that we're looking for in rehab. I am certainly not going to run you through an entire post-surgical rehab protocol, because that would mean we would be here for forever and ever and ever. But I just want to highlight some of the differences between what we're looking for in dancers versus what we might see commonly in other athletic populations. So the first phase of post-surgical rehab, and we often divide post-surgical rehab into different phases, like phase 1, phase 2, phase 3, based on rough timelines. The first phase of post-surgical rehab really looks very, very similar, regardless of what activity or sport someone is participating in. Immediately following surgery, so like within the first few weeks, our big goals are decreasing people's pain, decreasing the swelling, and really focusing on range of motion, especially extension range of motion. That is like number one priority in the first few weeks. It's really trying to make sure that people can get their knee fully extended. And in dancers, this is potentially even more important, because we often have a little bit of a degree of hyperextension. So we're not just looking at getting 0 degrees of extension. We actually want to restore them to whatever their natural extension range is, which in dancers could be, 5 degrees, or if we're working with dancers who are more hypermobile, maybe even closer to like 10 degrees of hyperextension. So we're really focusing on that immediately. We are less concerned about flexion range of motion right in the beginning. Obviously, eventually we want people to be able to fully flex their knee, but in terms of looking at overall outcomes, it is that extension range of motion that is really, really, really important right in the beginning, and ideally achieving that as soon as possible, like within the first 2 weeks post-surgery. And, in some cases, even sooner than that, we really want full extension or even a little bit of hyperextension. By somewhere between 3 and 6 weeks, and again, it will depend on how much damage there was in the knee, we want like general full range of motion. So even then focusing a bit more on flexion, but at the beginning, really focusing on extension. We, in those beginning stages, because there's not so much that we're doing with the knee, we're also really focusing on all the other areas of the body around the knee. So making sure that we're maintaining calf strength, we're maintaining hip strength, we're maintaining core strength, we're using the other side of our body and all of those things. So a lot of the rehab actually looks like working out other parts of your body and not necessarily doing so much for the knee right at the very beginning. That's not to say we're not doing stuff for the knee. We absolutely are. But a lot of it is focused on maintaining other parts of the body. As we get closer to the 6 week mark, that's hard to say, post-surgically, we're looking a lot more at specifically strength of that leg. So starting to do things like, leg presses, if you have access to like a reformer or a shuttle machine or a leg press machine in a gym or things like that, doing limited range wall squats, little step ups on small height steps, things like that, where we're starting to build up specific leg strength, and also introducing some cardiovascular training. So usually this is going to be a bike at this point in rehab. It helps with range of motion, but also helps us to just start to get a little bit of cardio work happening. As we progress through the sort of like next sort of, from 6 weeks on to like 9 weeks or 12 weeks, it's really a lot of quadriceps strengthening, general leg strengthening, increasing cardio, and then really starting to work on proprioception. So that's like our balance perception exercises. And for dancers in particular, we want to be looking at that proprioception specifically on single legs, because for things like turning and things like that, we need to make sure that we have adequate balance and proprioception. So that's kind of what we're focusing on. But like I said, at this phase of beginning, kind of, the first few months, it's really going to look super, super similar to any other athlete who's rehabbing from an ACL. In the next phase, so again, this is going to depend a little bit on the athlete or on the dancer, but maybe looking at around the 12-ish week mark, we're going to start to introduce some more dance-specific things. So this might be starting to introduce working in a little bit of turnout and rotation and really looking at how the dancers are achieving that rotation. We still want to minimize the amount of torsion or twisting that's happening at the knee. So this is where we're going to really look at, okay, how is the dancer achieving turnout? Are they using their hip muscles appropriately? They're not forcing the turnout from the foot, which is causing twisting or torsion in the knee. So looking at that is going to be big. And we can start to introduce some, really basic kind of bar type work. We're not doing things like grand pliés at this point. We're not working in really cross-turned out positions like a crossed fifth or a crossed fourth or things like that, but just starting to introduce some more dance-specific stuff. We may also be starting to really do a lot more other supplementary training like Pilates training or gyrotonics or floor bar and things like that at that point. And then we also want to start to look, so from this kind of 3 to 4, I would say more like 4 months on, we want to start to look a little bit more on impact activities. And so in other athletes, 4 months is often is around the time where they might start to look at introducing jogging or running type activities. But in dance, our main activity is jumping, our main impact activity. We don't do a lot of running. We don't need our dancers to be able to, sprint at top speeds and then plant and cut and change direction. Those aren't the most functional dance-specific movement patterns. What we need dancers to be able to do is jump and change direction and land on a single leg and things like that. So when we are looking at starting to introduce more sport-specific, or in our case, dance-specific movements from anywhere in that sort of 3, 4, and up to 6 month phase, we're really looking at a lot more jumping and jump landing mechanics. So starting to work, obviously we'd start with working on unweighted jumping. So again, if you have access to a reformer with a jump board or a shuttle machine, we'll start with 2-leg jump landings in an unweighted position, and then progressing that to standing impact, 2-legged jumps, and then starting to initiate single leg or jumping from 2 legs. Taking off on 2 legs, landing on 1 leg is what I'm trying to say. So progressing, jump progressions that are being initiated. And so there's a much, much bigger emphasis on even plyometric training, but certainly all of this jump landing training than there might be in other sports that might have a bigger focus on running. So I would say that in phase 2 of rehab is the biggest difference between dance-specific versus other sport-specific ACL rehabilitation. So we're looking at a lot more jump mechanics, plyometrics, and then again, that proprioception, and especially single leg proprioception, to start to be able to think about introducing turns and things like that. Then we're going to move into what we call sort of phase 3 rehabilitation oftentimes. And this is usually around that sort of 5-6 month mark and then beyond 6 months. And this is when we start to really return to more specific dance skills. So again, more challenging jumps that are changing directions a little bit more agility and footwork that is faster footwork, changing direction footwork, things like that. We can start to gradually increase the amount of turnout dancers are using. So starting to introduce more of a 5th position or even 4th position, starting to look at grand pliés in turned out positions and things like that as well. So again, this phase 3 or approaching the 6 months of rehab mark is when it starts to actually look and feel a little bit more like dance. The other big difference between other athletic ACL protocols versus a dance protocol is depending on what style of dance dancers are participating in, we may also have to introduce a significant amount of going up and down from the floor. If you're working with somebody who only does ballet, this might not be as big of a consideration, but certainly for other styles where there's a lot of floor work and a lot of transitions, this can be one of the more challenging things for dancers to get back to, is those quick up and down off the floor. So again, when we move into phase 3 rehab, that's really dance specific rehab, that might be where you're spending a lot of your time as well, is looking at the mechanics of how are we getting on and off the floor. And this is where, again, sometimes if we have dancers who have had a patellar tendon graft, this can be challenging and be one of the bigger limiting factors because they may not be able to put weight through the front of their knee. That might still be really sore. And that's often just a time thing. They've looked at studies and looked at people at 6 months often still have a lot of anterior knee pain and tenderness and might not be able to kneel, but by 12 months, that usually resolves. So in these dancers, if it is a dancer who does a lot of floor work, we might be looking at a slightly longer timeline for them to get to the point where they are fully returning to dance. So that is by no means an exhaustive ACL rehabilitation protocol because it is obviously incredibly nuanced and it's going to be really different for each dancer. But I just wanted to highlight a few of the big differences, and it really starts to come into effect in that phase 2 and phase 3, where in a lot of rehab protocols, they're really looking at introducing running and running mechanics and changing direction and acceleration and deceleration with running. And for us in dance, we need to apply that to more of like a jumping sort of with more of a jumping lens. And so looking at, dynamic landings, 2-foot landing, single foot landing, taking off and landing on a single foot, taking off and changing direction with jumping, and a lot more plyometric. So whether that's like eccentric control of drop jump landings or looking at box jumps or things like that. So that's the one big difference. Second difference is the introduction of turnout and being really mindful of how much torsion there can potentially be at the knee if we are not using our turnout correctly and like really paying attention to the mechanics of our turnout. So that's kind of the second consideration. And then the third being those like transitions that are required for floor work for dancers. So up and down off the floor, rolling on your knees, any of those kind of floor work transitions. So I hope that was helpful for you. If anybody is in the unfortunate circumstance of needing to participate in ACL rehabilitation, you will be given, and your physical therapist or whoever you're working with will have a really comprehensive protocol that is given by the surgeon. And so it's broken down in much, much, much more detail. But I just wanted to highlight some of the differences because we know that although dancers are very athletic, they are not the same as other sports and other athletes, and a lot of these protocols are very much written for running sports, so something like a soccer or basketball or things like that. So we just have to take that into consideration and make sure that we're ticking all the boxes for our dancers to be able to return to stage. Like I said before, ACL rehab is a long haul. It is, I always tell dancers, like, expect at least 12 months, wrap your head around that, because sometimes the surgeons will still give people a little bit of I don't want to say it's like false hope, but they'll be like, oh, by 6 months you'll be jumping again, or you'll be running or doing things. And although that might be true that you might be introducing those things in rehab, that is not usually the point where anybody is ready to return to activity. It's definitely much more around that 12-month mark. So we need to mentally be able to prepare ourselves for that because it's a really, really long rehabilitation process. It's a really hard rehab to undergo. And again, some of it is like a little bit boring and pretty repetitive. And then it's this really long timeline that people are out for. So we have to consider all of those aspects as well. And a lot of dancers will need support in those areas in terms of maybe some mental health supports and things like that during the process, because it is a long haul. But hopefully that gives you a little bit more clarity on what the process might look like for ACL tears. Like I said, if you have not listened to last week's episode, I would encourage you to go listen to that because it touches just a little bit more on some of the preventative stuff and some of the other things that come up with regards to ACL tears in both a sports population as well as a dance population. So I hope that you found that useful today. If you have any questions or want to chat at all, please reach out to me. I love hearing from all of you guys. You can reach me on social media at dancephysioerica with a K, or send me an email, and my email is in the show notes. Thank you so much for listening, and I hope you have a great rest of your day.